Hello and welcome to our Kaweah Health bi-weekly community engagement webinar. Today we are at Thursday, February 17th, and I am joined from his office by Gary Herbst, our Chief Executive Officer. Good morning, Gary.
Good morning, Deborah.
How are you?
I'm doing great, thank you. Feels kind of weird though, not being in the studio next to you, but I understand we're employing this this version of technology this afternoon.
Yeah, and what's great about this is we can be anywhere in the world, Gary, and it still feels like we're just having a personal conversation.
All right.
All right, so let's go ahead and jump in with the numbers. I feel like we have some good news in that respect. So can you start off with those?
Yeah, and it's good to be back. It feels like I've been gone for a while, so good to be back with everybody. And as I have been doing for probably a few months now, really just kind of focusing on what's going on here at the hospital, as opposed to statewide or countywide. So as Deborah just alluded to, it is getting better here. We're now in this fourth surge, the Omicron surge, which I think at the highest point over the winter, we had about 135 COVID positive patients that were in the hospital. Kind of compare that to roughly the 170 that we had in the hospital last winter. So definitely Omicron wasn't as severe and resulting in as many hospitalizations as some of the previous variants have. But today I'm pleased to report that we're we have 83 COVID positive patients that are in the house today. One of the things I think is quite interesting, and I don't know if I've shared this previously, but when we were going through the Delta surge or last winter's surge, virtually every single one of our COVID positive inpatients were in the hospital because of COVID. That was their primary diagnosis, suffering from severe hypoxemia, low oxygen saturation. Many of them sitting down in the 70s and even 60s. But Omicron has behaved a whole lot different. So only about 50% of those 83 COVID positive patients are in the hospital today are here because of COVID, that's their primary diagnosis. The other half do have COVID. We test every single patient that is admitted to the hospital. We test them for the flu and we test them for COVID. But about half of them that are positive for COVID, that's not why they're in the hospital. They're here for some other primary reason, and COVID is a secondary diagnosis. So we still include them in our count because they are COVID positive and they are an inpatient, but I thought that would just be interesting to all of you. We continue to be a very, very busy hospital. Interestingly, we actually have more critical care beds available than general medical surgical beds. So the question of how many ICU beds do we have and how many of them are available today. We have 41 ICU beds in the acute medical center, 21 of them on 2 West, our medical ICU, and then another 20 in the obsequious wing in our cardiac ICU unit. And as of this morning, we had 10 of our COVID patients that were in an ICU bed. So again, much different than what we were experiencing last winter when we would routinely have mid-20s, even pushing 30 COVID positive patients in the ICU. And only 6 of those 41 ICU beds were actually available. So 10 COVID patients in the ICU, but only 6 beds of the 41 that were actually open. So still pretty tight in critical care. And as I mentioned, while COVID numbers are falling, we have been consistently running at more than 100% occupancy. So we have 344 adult beds across the acute medical center. That actually includes our 12-bed pediatric unit that we're using for adult overflow. And so as of 7 a.m. this morning, 323 of those 344 beds had a patient in them. That represents about a 94% occupancy rate. But we also had another 30 patients that were in the emergency department that a determination had been made to admit them, and they were being cared for in the ED as if they were an inpatient, but they're just waiting for a bed to open up. So if you count them as an inpatient as well, then we're running at 103% occupancy rate. So that's a little bit better than the 110 to 115 that we were consistently running. And for the last couple months, routinely, we were holding 40 to 50 patients in the ED. So to be down to 30 today is a bit of a reprieve, but nothing, still much, much higher than what we'd experienced in pre-pandemic times. And then our vaccination rates still pretty much holding at about 82% of our employees. So we have about 1,000 employees that chose not to get vaccinated and were required to submit a formal declination for either medical or religious reasons. Almost 96% of our medical staff is vaccinated. Now, you may be aware that back a couple months ago that the governor announced that healthcare workers, to be considered vaccinated, had to get a booster shot. So not only did you have to get, the original 2 shots of Pfizer or Moderna or the 1 shot of Johnson & Johnson, but you also had to get that 3rd booster shot, or I guess 2nd booster shot if it's J&J. And if you did not get that, then you were not considered vaccinated, and you would have to submit one of those declinations and agree to be tested routinely. So originally we had till February 1st to get that booster shot, but that got pushed back by the governor to March 1st. We still have quite a few hundreds of employees that got the original vaccine that have still not yet got their booster. So we're trying to get, kind of a handle on who is going to, get boosted. It's going to be 100% of our previously vaccinated employees, or are there going to be some now that said, yeah, I got that original vaccine, but I'm not comfortable getting the booster. So that's going to be interesting to kind of work through that. So Deborah, those are the numbers as of today. And we certainly hope to continue to see our COVID numbers drop each day.
Okay, so I'm going to go back up to the hospital census, Gary. You talked about we're at 103%. So this is we're not alone in this story. Hospitals up and down the region are full. And so people have asked us over and over, why do you think health is on such the decline? Why do you think that our hospitals are full? Are we seeing any trends?
Well, it's quite a varied story up and down the state, and you've heard me talk about, and certainly with respect to hospitalized COVID patients, those counties, particularly in the Bay Area, that have incredibly high vaccination rates, pushing 80% of their communities, they have a much lower COVID occupancy experience than we're having here, even today, even with Omicron. There are definitely Fresno Regional Medical Center, St. Agnes, virtually all the hospitals in Fresno County are reporting similarly, intense occupancy rates, routinely over 100%. And I do think there are other hospitals in the state that are having that experience. But there's still quite a few hospitals, again, in the Bay Area, some in LA, that even have low occupancy rates. They have lots of open beds. And at times we've tried to transfer patients to these other hospitals, but it's really at the decision of the patient and the family, and they've generally not wanted to be transferred. So great question though about, why are we so full? Definitely the winter season is probably our busiest time of the year. although it's been a very light flu season. But we do, there's a lot of respiratory conditions out there, patients getting pneumonia, their COPD or asthma gets exacerbated in the winter. A lot of us in healthcare, and this is nationwide, speculate that it's been delayed care. People that do have underlying chronic conditions like COPD, maybe not well managed diabetes or kidney disease or, congestive heart failure, hypertension, that they while they normally would be managing their condition, well and seeing their physician and often and being very compliant, that they didn't. They kind of hunkered down at home, afraid to go to their physician, and as a result, their underlying conditions have, gotten worse to the point that they're ending up in the hospital. Because we're definitely seeing a lot of activity through the emergency department, and then those patients end up being admitted. So we're actually trying to study that a little bit deeper, having some of our clinical folks, really kind of delve into those admissions and see if we see some common themes and if we're able to deduce anything in terms of, why such a big influx right now.
Okay, thank you. So a community member recently had surgery at an outpatient facility that does not require COVID testing. So why do some facilities require it and others don't?
Yeah, good question. That pre-testing, it's not mandated by the state, so it's not required. But we made a decision, probably more conservative, although I do know a lot of facilities that similarly do the pre-screening, do the COVID testing in advance of surgery or procedure. But it really was a decision collectively made by our surgeons, our anesthesiologists, our nursing staff, to be, just a bit more safe. And it really is more for the protection of our employees. So generally anybody that has a surgery or has a procedure here, they go through our pre-surgery process over, we call it CATS, admission and testing services. So it's over on Court Street on our South Campus there. But our team performs that COVID testing generally within 48 to 72 hours prior to a person having their surgery. And we've done that, because they're coming from home. And the concern is that you might have somebody that's COVID positive, but is asymptomatic. And so if that's, the case, then, we're going to, generally in surgery, we're going to intubate the patient. And that's called an aerosolizing procedure. So if a patient does have COVID, but they're asymptomatic, and we then intubate them, we expose our surgeon and our anesthesiologist and the staff in the operating room to COVID. And so we're trying to, avoid that uncertainty, that not knowing that this patient might have COVID. Because if the patient does have COVID, we would normally postpone the procedure, but sometimes we can't. Just for the health and safety of the patient, we still want to go ahead and do it, even though we know they're COVID positive. But in that instance, then we can prepare for it. So we can make certain that everybody has very, well-fitting N95 masks, face shields. We're doing everything. We're treating, during that, while we're intubating the patient, we might have everybody stay out of the room except for the anesthesiologist and let the air exchange, clean the room before everybody goes in. So it's just, it's such a highly transmissible form of the variant that we're just taking extra precautions. So that's why you might find some facilities. I don't think at Sequoia Surgery Center, which is an outpatient surgery center, I don't think they do the pre-screenings of all their patients there. They may have at one time, but aren't doing that anymore. So, there may come a time where we are comfortable enough not to do it anymore, but we're continuing to do it right now.
Okay, so the same answer might then apply, Gary, for the next question. So the question that was submitted was, the state is lifting a requirement that people test negative before visiting hospitals or nursing homes. Does that line up with COEA's processes?
No, we have not received anything from the state. We've not received any word, whether through a governor's executive order or what they call an all facilities letter, an AFL letter that we receive frequently from the California Department of Public Health. We have not received anything indicating that this requirement is being lifted. So, to visit a patient in a hospital, you have to provide proof of vaccination or proof, if you're not vaccinated, proof of a negative COVID test, within, I don't know if it's 48 hours or 72 hours, but that requirement is still in place. And it's in place for all California hospitals. So unlike what this person has heard, we have not heard anything, and we searched for, looking on the CDPH website yesterday. We definitely, yesterday, I think the governor announced, or the state announced, that the order that had been put in place in mid-December, that to enter a store or a restaurant or some other business, whether you're vaccinated or not, you had to wear a mask. That was supposed to expire mid-January, but then got extended to mid-February. And because Omicron has really been dropping over the last several weeks, the infection rate, as well as the percentage of hospitalizations, the governor went ahead and lifted that. So that now means that vaccinated people can go into a restaurant or a store or a business without wearing a mask. But if you're unvaccinated, there's an expectation that you will still wear a mask. I think most areas are doing it on the honor system and are not requiring that you show proof of vaccination. If you're not wearing a mask and you go in, they're assuming that you are in fact vaccinated. But when the governor lifted the order, he specifically stated that this does not apply to hospitals. So we're still required to wear a mask in every setting if we're indoors, again, vaccinated or not.
I think it was hospitals or schools, right? Hospitals and schools.
Hospitals and schools, yes.
Yeah, the memes are going crazy right now, Gary.
I know. I understand the controversy around schools, and I mean, nobody's more anxious to take off their masks than we are, and we're probably going to be evaluating over the next coming weeks. I've heard of at least one hospital in California that has decided that with that change that occurred yesterday, though whenever folks are meeting, off campus outside of the medical center, whether it's in a classroom or a meeting room. I had a meeting at 7 a.m. this morning out at the Lifestyle Center in one of their conference rooms, and we're still all wearing masks and we're all vaccinated. And so we were asked, when can we take our masks off when we're in these kind of settings? So we'll continue to look at that as well.
Okay, thank you. So a couple of non-COVID questions, yay. So the redistricting, we kicked off redistricting, changing the zones, and we kicked that off about a month and a half ago, and we had another meeting last month. And so a couple of questions about that. First of all, how many maps have been submitted by community leaders or community members? And how many meetings are we required to have? And when will you choose the final map?
Yeah, great questions. Just like the country, states, counties, cities, and special districts with the decennial US Census that was taken in 2020, we are now required to redraw the zones that lie within the district. And just to remind folks that the Kauai Delta Healthcare District is 183 square miles, encompasses all of Visalia, Goshen, most of Ivanhoe, and a little bit of Farmersville. And so that 183 square miles is then divided up into 5 zones that are supposed to have relatively the same population count within each of those 5 zones. And so that's what we've been working on. We have received 2 maps from the same community member, although the community member, the night he presented them to us, he withdrew one of the maps. He himself did not like it and did not want it to be considered. So we have 1 map from a community member, and we have 5 maps that have been drawn by our consultants. So the board currently has 6 maps to consider. It is, as a healthcare district or a special district, they are required to only have 1 public meeting before they take action to adopt a new map and new zones. But our board decided they wanted to make it more inclusive. We haven't done this in a long time, and this does kind of set the direction for the next 10 years. So they are holding 4 meetings. The first one was held in early February. We just had our second meeting the first meeting back in early February was kind of just an overview. We weren't yet looking at maps. Our consultant introduced himself, and then this last meeting we just had last week, we got to look at the different maps. We have another meeting scheduled in March, and then a final meeting scheduled in April. The board has until April 17th to take action, and they can accept maps from the public all the way up to that date. Although as of today, February 17th, we haven't received any additional maps since our meeting of last week, but we certainly are, continuing to be open for that. If you go onto the Kauai Health website, there is a link and information that really spells this all out, and it gives a schedule of the meetings, where they're going to take place, what time, the dates, but also then has a program to help you draw your own map if you are interested in submitting a map. So it's been a great process. We actually, the board has received a lot of positive feedback from the public that's been in attendance. We've had a few folks from the League of Women Voters, others from different agencies, and they really commended the board on their just open, transparent approach to it, and really engaging with the community. And so it's actually been a very positive and enlightening experience.
So what would happen if they redrew the lines and 2 current board members are in the same area?
Yeah, that was one of the more complex questions and answers. And so a number of the maps do result in that. So so right now we have 5 zones, zone 1 through 5, and there's a board member in each of those zones that was elected by the people that live in that zone. So with a number of the maps, it appears that these new proposed zones that generally we'll see generally one zone where now we have 2 board members in that same zone. I don't think we ever saw one that had 3, or that we had 2 zones with 2 members each. But generally we would see one zone that had 2 members. So I think the best way to explain it is to give you an example. So let's say that Dave Francis, who currently lives in zone 4, we redraw the lines, And now all of a sudden, Mike Olmos is also in Dave's zone. Dave is up for re-election in November of 2022. Mike is up for election in November of 2024. So if the board adopts that map that has those two board members in the same zone, and let's say Dave wants to run for re-election in November 22. So Mike has to make a decision. He can run for election in his new zone, Dave's zone, and appear on the November 22 ballot. And if he loses, then he still gets to stay on the board until November of 24. He doesn't represent that zone that no longer has a board member living in it, but he still remains on the board till November of 24. When November 24 arrives, Mike comes off the board. He cannot run for election in his new zone because Dave's already been reelected and he still has 2 more years on his term. So Mike would go off the board, and then all those board members that are up for election in November 24 that live in a zone. So Garth and Ambar are both up for re-election in November of 24, and they would run for re-election in the zone that they now currently live. But then there would be new candidates that would file to run in that zone that Mike used to be in but was no longer in, that didn't have a current board member. So new folks would run for election that lived in that zone. What could happen is perhaps, if Mike did decide to run against Dave in his zone and Mike won, then Dave would go off the board because his term would be up in November 22, and Mike had just been elected to a new term that would run till November of 26. So that's about as simply as I could explain it. But yeah, it's a little complicated, and that's certainly one of the things that the board will wrestle through. There are different objectives that the board is trying to achieve. The first one is a legal objective that you must distribute the entire district population, which is about 160,000 people, that you pretty much have to distribute it equally among those 5 zones. In fact, there's population deviation. So you can be slightly over or under, the exact calculation of even distribution. But when you add up all the over under deviations across all 5 zones, it cannot be more than 5%. So you have to stay in very tight, and all the zones that have been drawn by the consultant actually achieve perfect deviation. They have an aggregate deviation of 0. So well under, obviously, the 5%. The other requirement is that you need to respect what they call communities of interest. So that if there are natural blocks of people or voters that live in very defined areas of the city or within the district, you try to keep those intact. You don't try to split them up or fragment them in certain ways. And if you were to look at our current map, you'll see that it's pretty zigzaggy, and it definitely breaks up a lot of those communities of interest. So trying to bring that back together. And then the other is what they call, CVAP, Citizen Voting Age Population, Citizen Voting Age Population. So you have the total population of 160,000 and 30,000 something per zone, but then how many of those are actually registered voters? So that's called the CVAP. And you want to have your zones be reflective of the people that live within those zones and that district. And so, over the last 30 years, there's been a significant change in the ethnicity and the distribution of our population throughout the healthcare district. And so, within the healthcare district and within the voting members of the healthcare district, it's now more than 60% Hispanic. And so one of the objectives then would be to create zones where you have a majority of the voting public in that zone to be Hispanic. And the folks that have been in attendance, particularly this gentleman that submitted his map, his objective was that at least 2 of the 5 zones would be Hispanic CVAPs. And to be a CVAP means you have to have at least 50% or more of the people that live in that zone are of a particular ethnicity. And so he wanted to have at least 2 zones that had at least 50% Hispanic voters in those zones. He also defined what I guess his definition or some agency's definition that what's considered to be an effective CVAP zone is when you have 55% or more of a particular ethnicity, because then it's determined that it's more than just a simple majority. It's a stronger voting bloc and increases the probability that a person of that ethnicity, in this case Hispanic, would have a greater probability of getting elected to the hospital board and representing the people that live in their zone. And so that's kind of the third objective that the board is trying to achieve, is to be respectful and supportive of the ethnicity makeup of the people that live in the health district. A fourth objective that they absolutely can consider in their deliberations is what this will do to the distribution of the board members. Is there one or more maps that don't create this disruption in the board and leaving it with a zone that has no board member in it for a couple of years? So the board definitely could take into account a map that achieves those first 3 objectives, but still leaves a board member in each of the 5 zones. So that is something that the board can consider as well. So it really hasn't had any discussion around that 4th objective. And I suspect at our March meeting, I think it's March 8th or 9th, that discussion will start unfolding.
Okay, thank you. Because I had a kind of a dumb question, or you might think it's a dumb question about that. So if we take your same scenario and Mike and Dave are in the same zone once it's redone, then would the board appoint someone to the empty zone, or would they just allow that to sit empty? Kind of what you were saying there.
Yeah, it sits empty because even if Mike decides he's not going to run against Dave in the November 22 election, he still gets to stay on the board until his term expires in November of 24. But he no longer now represents any particular group of people living in the zone. He no longer lives in his the zone that he used to be in, and so that zone actually goes 2 years without actually having a board member that specifically represents them. But Mike still remains as a member of the board.
Okay, very interesting process. So we will all be watching that. Thank you, Gary. So lastly, Gary, the 2021 Leapfrog Awards were just announced. And so what are the awards that Cahuilla has just been honored with?
Yeah, so this is kind of like Mom's brag book. So I hope you'll indulge me here because we are very proud of the recognition that we received. It's not why we do what we do, but it's always nice to know that our efforts are resulting in, great outcomes for our patients. So yeah, actually a couple things. So an organization called Leapfrog this last fall published its semi-annual safety grades. And so Kauai Health received a letter grade of A for patient safety and quality. It's the highest letter grade that's bestowed by the Leapfrog group. So every fall and every spring, every 6 months, they issue a new grade, and it's based on the avoidance of hospital infections and mortality, patient experience, a whole host of different clinical measures, and so we were very proud of that. Also back in the fall, another organization by the name of Health Grades released all of its awards. They rate 4,500 hospitals across the United States in different areas of care, like cardiac, neurosciences, pulmonary care, gastrointestinal, critical care. So awards in all those different specialties of care. And so we received many awards. In cardiac, we were named for 6 years in a row now as receiving the Cardiac Surgery Excellence Award. For the 5th year in a row, we were named one of the top 50 cardiac surgery programs in the nation, in the top 5%. 5 stars in coronary bypass surgery for 6 years in a row, 5 stars in valve surgery for 2 years in a row, 5 stars for the treatment of heart attacks, and 5 stars for the treatment of heart failure. In neurosciences, we were given the Stroke Care Excellence Award for the 4th year in a row, rated one of the nation's top 10% of hospitals for the treatment of strokes for the last 4 years in a row, and 5 stars for the treatment of strokes for now 8 years in a row. In terms of pulmonary or respiratory, we received for the 9th year in a row the Pulmonary Care Excellence Award, rated in the top 5% in the country for 2 years in a row, top 10% for 9 years in a row. Received 5 stars for the treatment of chronic obstructive pulmonary disease, or COPD, for 2 years in a row, and 5 stars for the treatment of pneumonia for 9 years in a row. For the first time, we were given 5 stars for the treatment of gastrointestinal bleeds. And in critical care, which largely takes place in our ICUs and ICCUs and trauma in the ED, we were given the Critical Care Excellence Award for 3 years in a row, top 5% for critical care 2 years in a row, top 10% for 3 years in a row. And sepsis, which is one of the leading causes of death in this country, for 10 years in a row, we've received 5 stars for the treatment of sepsis and 5 stars for the treatment of respiratory failure for 4 years in a row. The award that was just announced, I think it was last week, and I think is the one you were alluding to, Deborah, is for the 4th year in a row out of those 4,500 hospitals across the United States. Kauai Health was named one of the best 250 hospitals out of those 4,500. And we received that designation based on a review, I think, of more than 30 different clinical measures around mortality and complications. And so our performance over this measurement period set us apart, literally ranked us in the top 5% of performance, again, across these 4,500 hospitals, putting us into that class of hospitals for the very best 250. So to do it 4 years in a row is exciting. Again, it's just really a testament to just the excellent care that our physicians, our advanced practice providers, our nurses, all of our clinicians, but all of our staff, all of those that are in support positions, administrative positions that are all helping support the team so they have the resources and the tools they need to provide great care. And that really translates, being one of the top 250 really translates into excellent care for our patients, safe care, great outcomes, high quality, and we're just excited to celebrate that with the community.
Yeah, Gary, as you were listing off those awards, we needed an applause track or something because I'm like, we need some noisemakers, but no, it is a huge achievement. And
well, I'm hoping that it's going to be on the front page of the Times Delta tomorrow.
Oh, yay, yay.
Yeah.
That would be great. Well, Gary, we've answered all of the questions, and so let's give everybody some time back. But if you would like to close this out with some words of inspiration, like you do every time.
Yeah, thank you, Deborah. And again, it's great to be back with all of you, and thank you for staying with us. We're not celebrating, the second year of COVID. We will be recognizing it on March 13th. Will mark the 2-year anniversary when we tested our first COVID positive patient and instituted the hospital emergency incident command system, set up our command center, popped up the tents over in the multi-service center parking lot, and began testing our community for COVID. And it's hard to believe that we've been at this as a society, as a community, as a country and a world for 2 years. I know folks are so tired of this and want this to be over, and I see a light at the end of the tunnel, and I thank you all for your continued support of our organization, your well wishes, the time you take out to thank our staff. And I just got a letter from a gentleman this week just applauding the incredible care that he and his wife received in our emergency department. And he said it was like watching orchestrated chaos. He saw, just the sea of humanity, and but just the incredible waltz, I'll use that term, that he witnessed as our healthcare team went about its job. So Monday we celebrate President's Day, kind of a patriotic moment for all of us, and I just feel so blessed to be a part of this community that's really come together to support one another, and just say thank you. And I hope you all have a wonderful 3-day weekend and continue to be safe and healthy, and we'll talk to you soon.
All right, thank you, Gary. Thank you, everybody, for joining us.
Bye-bye.